Hi, my name is Hallie, and I'm a graduate student in applied nutrition at the University of New England. And today I'm presenting to you a research proposal entitled Alpha Linolenic Acid Intake and Migraine Prevalence in Premenopausal Women. Migraine is a common condition that disproportionately affects women in a 3-to-1 ratio to men. It can also be debilitating. Migraine has been found to be the second largest cause of disability worldwide in women ages 15 to 49. While new and effective medications exist, they do not always provide adequate relief, and many people discontinue them due to side effects and cost. So there is a need for low-risk, affordable, adjunctive therapies for migraine prophylaxis. While the etiology of migraine is a complex combination of genetic, environmental, hormonal, and inflammatory factors, neuroinflammation is increasingly understood to be central to migraine pathogenesis. There has been an interest in omega-3 fatty acids in migraine relief due to their anti-nociceptive, anti-inflammatory, and antioxidant effects. Omega-3 fatty acids are the precursors to a host of lipid mediators called oxylipins, and these include things like prostaglandins and leukotrienes, and they're thought to have a modulating effect on migraine. The nerve endings of the trigeminal nerve, a key structure in the pathophysiology of migraine, has an unusually high number of oxylipin receptors. This suggests that omega-3 fatty acids could be protective for migraine development. Furthermore, omega-3 fatty acids have been found to be low in the American diet. This is true both in absolute quantities, which fall below the recommended intakes, as well as the ratio of omega-6 to omega-3, which some research suggests may be especially relevant. Most of the research into omega-3 fatty acids and migraine have focused on EPA and DHA. Studies have found that these fatty acids may be effective for preventing migraines. A 2025 systematic review found that EPA and DHA were moderately effective at reducing migraine symptoms. And a 2024 network meta-analysis compared EPA and DHA to pharmaceutical treatments and found that EPA and DHA were more effective than any of the medications studied for migraine prophylaxis. Only 2 studies have looked at ALA and migraine, and these used a shared interventional data set in which ALA was combined with L-carnitine. The studies found that supplementation with ALA combined with L-carnitine reduced biomarkers of inflammation and oxidative stress and reduced the frequency, severity, and duration of migraines in Iranian women aged 20 to 50 with physician-diagnosed migraine disorder. So there is a gap in the literature regarding ALA and migraine outcomes, especially dietary ALA. Our study question is there an association between dietary ALA intake and migraine prevalence in women ages 20 to 40? We hypothesize that increased ALA intake will be associated with a decreased odds of experiencing migraine. This will be a secondary analysis using data from the National Health and Nutrition Examination Survey, or NHANES. NHANES has been collecting health and nutrition data on representative samples of Americans since 1999. In the 3 study cycles between 1999 and 2004, the NHANES questionnaire included the question, in the past 3 months, have you had severe headaches or migraines? Diet data was collected through 24-hour diet recalls, and this included ALA intake. More recent NHANES cycles have not included a question on migraines. However, any biological mechanism underlying an association between ALA and migraine would not be expected to have changed. Omega-3 supplement use, which could confound the data and will therefore be an exclusion criteria, was lower during those years and has since risen, which will be beneficial for our sample size in our study. This study will be in women ages 20 to 40. Exclusion criteria will be pregnancy, lactation, use of omega-3 supplements, use of prescription migraine medications, chronic use of ibuprofen or Tylenol, those with missing or incomplete diet recall data, and those with implausible energy intakes. During the included years, 15,230 people answered the question on severe headaches and migraines. The sample size is expected to be sufficiently large even after applying exclusions. Descriptive statistics will be used to describe the final population sample and then to break the data into quartiles by ALA intake. It will be ordered in order and find the quartiles based on the 25th, 50th, and 75th and 100th percentiles. Then we will use that for inferential statistics. Our first test will be a chi-squared analysis of migraine prevalence across quartiles to answer the question of whether there is a difference in migraine prevalence between discrete ALA intake levels. Then secondly, we will assess the magnitude of any association using logistic regression to look at the odds ratio at the 95% confidence interval of migraine per unit increase in ALA intake. Starting with an unadjusted model for ALA intake, we will add confounding variables in a stepwise manner. These will include overall diet quality as measured by the healthy eating index, caloric intake, and the use of lipid metabolism altering medications like statins, and cardiovascular disease history, as well as demographics and smoking history and physical activity. So there's a paucity of research into ALA and migraine, even though there is good data showing that other types of omega-3 fatty acids are effective at preventing migraines. If this study produces significant findings, it would add to the body of research showing that omega-3 fatty acids can be helpful in migraine prevention. If an association is found between ALA intake and migraine prevalence, experimental studies should follow. Interventions aimed at increasing dietary ALA in women ages 20 to 40 could be a low-risk, affordable, and accessible adjunctive therapy. There are several limitations to this study. First, the wording of the NHANES questionnaire is such that we will be capturing all types of severe headaches, not just migraines. And this could result in a dilution of the effects of ALA on migraine prevalence. Second, the binary yes-no nature of the question is not as comprehensive as using a validated migraine scale like the MIDAS, which is the Migraine Disability Assessment Score, or HIT-6, which is the 6-item headache impact test. And these capture much more information on the frequency, severity, and duration of headaches and migraines. And third, NHANES relies on self-reported data and diet recalls, both of which make it susceptible to recall bias. So that concludes my presentation. Thank you so much for watching, and here are my references.